Welcome to yet another session in the ARDS series. This lecture will be dealing with the essentials of prone positioning in ARDS. This lecture will be based on the Proseva trial, which is really the watchdog for proning, and what are the essential steps which are to be followed while proning a patient in ARDS. First and foremost, when to prone a patient, endotracheal intubation and mechanical ventilation both in the ARDS for less than 36 hours. Severe ARDS is defined as PF ratios of less than 150 millimeters of mercury and an FiO2 of more than 0.6, a PEEP of more than 5 centimeters of water, and a tidal volume of 6 ml per kg of predicted body weight. The criteria in the trial, Proseva trials, were confirmed after 12 to 24 hours of mechanical ventilation in the participating intensive care units. So we see that when to probe severe ARDS in less than 36 hours of the mechanical ventilation and endotracheal intubation, and at least 12 to 24 hours of the mechanical ventilation. The guidelines for the prone position placement, the protocol stated that 3 to 4 persons were required for the procedure, one of them being dedicated to the management of the head end of the patient, the endotracheal tube and the ventilator lines. This person at the head end of the bed has to coordinate the steps of the procedure. The other person stood at each side of the bed. In the first step, the direction of the rotation to the left or to the right was decided, giving priority to the side of the central venous line. The length of the vascular and the ventilator lines was checked for appropriateness. The endotracheal tube and gastric tubes were secured, and the patient knees, forehead, chest, iliac crests were protected using adhesive pads. The patient was then moved along the horizontal plane to the opposite side of the bed, selected for the direction of rotation. In the third step, the patient was moved in the sagittal plane and maintained in that position for a short while attached to the cardiac electrodes to his or her back and to set a new bed sheet. In the last step, the patient was turned to the complete prone position. The body was placed in the horizontal position at 180 degrees. Abdomen was not supported. The head was turned alternately to the right or left every 2 hourly. The upper limbs were placed alongside the body. Parts were padded with changing the position to avoid disconnecting the ventilator or kinking in the vascular lines. When to terminate proning. The criteria for stopping proning, as in Proseva trial, if there was oxygenation improvement, which was defined as PF ratios of more than 150 millimeters, with a PEEP of less than 10 centimeter and a FiO2 of less than 60% in the prone group. These criteria had to be met in the supine position. The same criteria have to be met in the supine position at least 4 hours after the end of the last proning session. So this was important, that whenever we are proning a patient, whenever we make it supine, we have to wait at least 4 hours, get the PF ratios more than 150 with a PEEP of less than 10 and FiO2 of less than 0.6, and if we are getting this, we can terminate the further pruning sessions. PF ratios deterioration by more than 20% relative to the supine before 2 consecutive prone sessions. Suppose we have pruned the patient and we are getting a deterioration of PFs by more than 20%, then again we may terminate the pruning session. Any complication occurring during the prone session leading to its immediate interruption, such as non-scheduled extubation, mainstem bronchus intubation, endotracheal tube obstruction, hemoptysis, saturation falling less than 85%, or a PaO2 of less than 55 millimeters for more than 5 minutes under the FiO2. Cardiac arrest is happening, heart rate less than 30 beats per minute for more than 1 minute, systolic blood pressure falling less than 60 for more than 5 minutes, or any life-threatening situation, the clinician decided to stop or immediately terminate the proning. So this was the criteria which were used for terminating the proning protocol as in Proseva trial. How many hours and for how many sessions? Patient in the prone group underwent their first pruning session within 55 minutes after once the randomization has occurred. The average number of sessions were almost 4 per patient, and the mean duration of session was 17 plus minus 3 hours. All patients in this group underwent at least one prone positioning session. In the prone group, the patients were ventilated in the prone position for 73% of the 22,334 patient hours spent in the ICU from the start of the first session to the end of the last session. So we found that there was a definitive survival benefit in the prone group as compared to the supine group as seen in the Kaplan-Meier survival curve. Now, what was the primary endpoint which was measured in the Proseva trial? The primary endpoint was mortality at the day 28. Secondary endpoints were mortality at day 90, the rate of successful extubation, the time to successful extubation, the length of stay in the ICU, complications, and the use of non-invasive ventilation. Tracheostomy rates, the number of days free from organ dysfunction, ventilator settings, measurement of arterial blood gas, and respiratory system mechanics during the first week after randomization. Successful extubation was defined as no reintubation or use of non-invasive ventilation for 8 hours after extubation. The patient had undergone a tracheostomy. Successful meaning from the ventilator was defined as the ability to breathe unassisted through this tracheostomy cannula for at least 24 hours. So this was the protocol which was used for the Proseva trial. We will in the coming sessions again analyze deeply about the Proseva, the findings of the Proseva trial. So as this session was dedicated to the fine tuning about the proning, so we would again go through the pre-proning checklist. What is the critical care pre-proning checklist? Before you prone the patient, just review your team. A physician is available to manage any changes. If inexperienced team, require physician at the bedside in addition to one respiratory therapist nurse and 4 nurses. Review indications and contraindications of proning. Emergency equipment should be ready. Review your guidelines and emergency procedures. Gather pillows, gel donuts from the operation room, soaker pads or blue pads for under the face, 2 flat sheets, barrier cream protective devices, ECG electrodes and leads, paper tape, eye lubrication, eye padding. Before proning, just assess the pre-oxygenation, ET and oral secretions, ET tube is secured or not, cap off unnecessary lines and tubes, dressings to be changed, apply posterior electrodes, remove front leads, eyes to be lubricated, eye patches applied and taped, wash face and apply barrier cream, apply protective dressing to iliac crest, gastric tubes to be secured, hold feed, chest tube is secured and in the midline, Foley's to be secured in the midline, ensure adequate analgesia and sedation, reposition equipments to allow easy access, prepare anticipated medications to be used prior to proning. Now, whenever the turn is occurring, it is identify the leader who is at the head end of the patient. Safety huddle, always to communicate the plan and outline emergency procedures. Remove and reposition ECG lead, place SpO2 on the limb farthest away from ventilator, tuck arm closest to the ventilator under buttocks, place 2 pillows on the patient, check chest and iliac crest, place flat sheets on the top of the pillow, roll top sheets together. Leader should guide all the movements. Slide patient away from ventilator, turn the patient to the side facing the ventilator, slowly complete the proning, extra caution with endotracheal tube lines and unfold and pull flat sheet so it flats under the patient head. Assess lines and tube for dislodgement. Reattach disconnected lines. Position arms in the modified swimmer crawls. Face in the direction of the raised arm shoulders and other arm at the side, palm facing up. Ensure pillow is under the shin and toes are off the bed. Place bed in the reverse Treadlenberg position. Reassess endotracheal cuff pressures and tidal volume. Monitoring. Always see for any kinks. Ear should not be kinks. Eyes lubricated. Tube secured. Reposition arm. Swimmer crawler. Shoulder dropped. Elbows below axilla. Clear oral nasal ET secretions. Examine knees, genitals. Technique for face. Ensure ET tube is secured. Gather staff. Respiratory therapist, respiratory nurses at head end of the bed. Place arms at the side of the body. The respiratory therapist to move face to the other side. Once facial repositioning is done, arm should be repositioned. Raise opposite arms. If cardiac arrest occurs in the prone position, immediately initiate CPR on the posterior part. Place one hand under the patient to landmark sternum. Place other hand on the supine and start CPR. Hard and fast. Call for help as soon as possible. Continuously ETCO2 monitoring to assess the quality of CPR and ensure that endotracheal tube is placed. That is why the ETCO2 should be more than 10 millimeters during CPR. Return patient to the supine if CPR is not effective. When team is prepared to safely reposition, immediately reposition the patient. Place pads in anterior posterior placements. Anterior can be applied with hardwood defibrillator. Defibrillate as per their ACLS guidelines. Return to the supine position. Again follow the safety huddle. One MD physician at head end of band, respiratory therapist at the ventilator for assistance in the airway management. The respiratory therapy, if not first deprone, nursing should be at each side of the patient. Each move must be done solely on the direction of the team leader, which is at the head end of the bed, and ensure synchronous movement. Reposition first, so head facing the ventilator. Place SpO2 on the limb closest to the ventilator. Tuck the arms furthest away from the ventilator and the patient's thigh. Place two soaker pads across the patient's covering posteriorly. Place flat sheets from head to toe. Roll top sheet together with the bottom sheet. The MD or the respirator should to communicate plan for turn to team. Slide patient towards ventilator. Pause to check ET tube lines tube. Turn the patient to side facing ventilator. Pause. Slowly complete the turn. Position flat sheet. Remove posterior ECG and elevate head end of the bed. These are the checklist which can be used. Again, these are the pressure points: the forehead, cheek, nose, chins, shoulder, clavicle, chest, breast and ribs, elbows, anterior genitalia, knee, tibial crest and dorsum of foot and toes. These are the pressure points which have to be secured and protected from pressure injuries or ulcers while we are proning the patient. Again, a prone position checklist which is adapted from the intensive care of the Faculty of Intensive Care Medicine. Prone position checklist for indication of ARDS with a PF less than 150. There is a before proning, time out and sign out. Time in, confirm members, look for contraindications, eye care, reintubation equipments are ready, secure endotracheal tube. So you can just keep on taking these things before you go for proning. Time out whenever you are in this position to prone, and sign out once you have done. Again check out on all these things. Results in the Proseva trial. The primary outcome was to study the 28-day mortality, which was significantly lower in the prone group as compared to the supine group. So in the prone group it was 16%, 38 out of 37 participants, whereas just double, almost double, 32.8%, 75 of 229. So there was a significant difference at day 28 mortality. There was again a significant difference in the mortality which persisted at day 90. A comparison of the two survival curve, as earlier in my earlier slide also I said that the Kaplan-Meier survival curve shows significant difference with the mortality being lower in the prone group as compared to the supine group. After adjustment of the SOFA and use of neuromuscular blockers and vasopressors at the time of inclusion, mortality remained significantly lower in the prone group than in the supine group. The rate of successful extubation was significantly higher in the prone group. Duration of invasive mechanical ventilation, length of ICU stay, incidence of pneumothorax, use of non-invasive ventilation after extubation and tracheostomy rate did not significantly differ in either in the prone or in the supine group. So there was no significant difference in these parameters. So complications, if we talk about complications in the prone group, total of 31 cardiac arrest occurred in the supine and 16 in the prone group. There was no significant difference between the complications with respect to the adverse effects in these two, prone and the supine group. Again, this was the primary and secondary outcome adopted from the Proseva trial, which showed a significant difference in the mortality at day 28 and day 90, and a successful extubation at day 90, again significantly higher in the prone group. So this was the primary and the secondary outcome analysis of the Proseva trial. Thank you for your attention. From this presentation we learned that when to prone, how to prone, when to terminate the proning, and what are the advantages of proning. Thank you. Again.